Let's take a closer look at how impetigo develops. In non-bullous impetigo, the bacteria Staphylococcus aureus or Streptococcus pyogenes exploit even the smallest breaks in the skin, whether from a scratch, insect bite, patch of eczema, or minor trauma. Once these organisms gain entry, they multiply in the superficial layers of the skin, leading to the formation of the characteristic honey-colored crusts. In contrast, bullous impetigo results from certain strains of Staphylococcus aureus that produce exfoliative toxins. These toxins spread within the epidermis, causing the skin to separate and form the larger, flaccid blisters typical of this form. While both types are caused by bacteria, the way they interact with the skin differs, which explains their distinct clinical appearances. To reach an accurate diagnosis, it is important to recognize that impetigo is primarily a clinical diagnosis. Cultures are not routinely necessary, but may be indicated in specific situations, such as when the lesions are severe or recurrent, if there is concern for resistant organisms, when the diagnosis is uncertain. Now let's turn to the current approach to treating impetigo. The main goals of treatment are to eradicate the infection, prevent its spread, and shorten the duration of symptoms, ensuring both patient recovery and public health safety. According to recent clinical guidance, the choice of therapy depends on the severity and extent of the infection. For limited lesions, topical antibiotics such as mupirocin or retapamulin are considered first-line therapy. However, when the infection is numerous, widespread, or when topical treatment is impractical, oral antibiotics are recommended. It's important to note that antibiotic resistance is an ongoing concern, particularly with methicillin-resistant Staphylococcus aureus, MRSA, and variable streptococcal susceptibility. Therefore, treatment selection should take into account local resistance patterns and individual patient risk factors. Penicillin alone is generally ineffective for impetigo, as S. aureus frequently produces beta-lactamases. You may be wondering, when should impetigo be referred to secondary care? While most cases can be managed in primary care, certain situations require specialist input. Referral is indicated in severe or extensive disease, such as when lesions are widespread, covering large areas of the body, progress rapidly, or are accompanied by systemic symptoms like fever or malaise. Any suspicion of deeper infection, such as cellulitis, also warrants prompt referral due to the risk of invasive staphylococcal infection. Referral is also necessary if first-line treatment fails. This includes cases where there is no improvement after 3 to 5 days of appropriate therapy, recurrent impetigo, or suspected antibiotic resistance, for example, MRSA. Such cases may require culture-guided therapy or alternative antibiotics. Diagnostic uncertainty is another important reason for referral. If there is doubt whether the lesion represents eczema herpeticum, herpes simplex, varicella, staphylococcal scalded skin syndrome, or bullous autoimmune disease, secondary care evaluation is warranted, particularly in neonates or immunocompromised patients. Speaking of neonates, any bullous lesions in newborns, suspicion of staphylococcal scalded skin syndrome, or systemic signs should prompt immediate referral. Neonates can deteriorate rapidly, so a low threshold for specialist input is essential. Children and adults who are immunocompromised, for example due to diabetes, immunosuppressive therapy, malnutrition, or chronic skin disease, are at higher risk of complications and should be considered for referral even with seemingly mild infections. Referral is mandatory if complications are suspected, including cellulitis, lymphangitis, osteomyelitis, sepsis, or post-streptococcal glomerulonephritis manifested by hematuria, edema, or hypertension. Finally, recurrent or outbreak cases may require secondary care or infection control involvement, particularly when multiple family members are affected, there is a school outbreak, or infections recur despite proper hygiene measures. In summary, while impetigo is often straightforward to manage, recognizing these red flags ensures timely referral and prevents serious complications. Thank you for watching. Don't forget to like and subscribe, and stay tuned for our next video on MCQs and exam tips.